Dr. Sam Shamardi, welcome to Sydney, and thank you for speaking to Dental Files today.
Thank you.
Sam, you're a specialist periodontist, so can I start by asking you, how did you become interested in the topic of noise-induced hearing loss in dentistry? Seems a bit far from perio.
Yes. For me, once I started practicing as a clinician, I noticed pretty quickly that it was not like dental school or residency where you're treating one or two patients a day over a pretty prolonged period of time. And I noticed in private practice, working a much higher volume, that, we're being bombarded daily with all these high-level sounds, the high speed, the suction, the ultrasonic. It didn't take very long into my practice career to notice that the sounds were very loud and they were having an effect on me, and they were a nuisance. I really was curious as to why these sounds were something that wasn't addressed within our field, why we didn't have something that could help protect us against it. And I started doing some research, and I saw, sure enough, there was nothing in the dental field that was kind of designed for us to help address this problem. And that's kind of what led me into trying to find a solution for us as dental professionals.
During your lecture, you drew an interesting analogy between periodontal disease and hearing loss. Could you elaborate on that a bit more?
Yeah, absolutely. I think what we see as dentists is that we have patients on a daily basis that come in, and we try as clinicians to give them the best treatment and explain to them the process in terms of periodontal disease, bone loss, pocket depth, mobility on teeth. And what we find, of course, is as soon as we pose a problem to a patient and show them what's going on, their first reaction is that they're not having any pain. They don't understand, why they're here to see us. They feel perfectly fine. They haven't had issues, and they don't know anything is going wrong. Meanwhile, of course, you look at the radiograph and you see they've got pretty significant bone loss. You probe them and you see there's severe pocket depth, and there's bleeding and, all sorts of signs and symptoms that tell us the exact opposite. But our patients don't know that, because more often than not, there isn't a lot of pain and symptoms associated with a lot of periodontal issues. At the same time, when you look at hearing loss and the steps that are involved, especially noise-induced hearing loss, you'll see that the parallels to dentistry are quite striking. You'll see that when you start developing hearing damage, it doesn't cause any pain. There aren't any obvious signs. It is actually not until you're at stage 3 of hearing loss, so you've gone from stage 1 to stage 2, all the way up until stage 3, before you even begin to perceive yourself that you have any type of issue with your hearing as well. And of course, once you've reached that point, when it comes to hearing loss, your hearing is damaged permanently and irreversibly, and there's really no going back. And the same thing what happens with our patients. The only time you'll see them come and actually want to see you is once they have an abscess and they're in a lot of pain. But usually by that point, the tooth is so far gone that, there's not much we can do to help them. So I see a lot of similarities between those, and that was something I tried to point out, with this topic.
Well, if you'll pardon the pun, it's not a topic that we're hearing very much about. But I myself can certainly identify with the progression you've just described, because as a practitioner of some 40 years standing, I've certainly noticed a slow and gradual hearing loss. I have never had any evidence, but I'd be pretty sure that my practice career would have contributed to that. But when you look around, have you found officially, say at the ADA in the United States or anywhere, has there been much information about this?
It's an interesting point. And again, when I first was trying to, research the topic on my own, I thought the same thing. I thought, well, I know a lot of my own friends and colleagues and people that have been working in the industry for many years who complain about having hearing damage and not being able to hear things the way they could. And I just thought, well, how come our dental association, and how come there hasn't been things out in the literature to tell us about this? And I was really surprised to find that when I did the research, there actually were quite a substantial amount of literature out there on the topic that did address the amount of hearing damage that occurs, that across the board, told us that wearing ear protection of any form would be of big help to us. But what I found is, even though there is some literature that clearly tells us of this, it's just something that we're not very much aware of as clinicians, and it's something that our dental associations and just our community as a whole does not really spend a lot of time addressing and speaking about. It seems like our interest is more in the newest composite and bonding agent, as opposed to, something that's really causing us permanent damage to one of our 5 senses.
Besides missing out, say, on the nuances of fine music or can't hear your partner at a restaurant, which I can certainly attest to, How does this affect the quality of dental practice?
Dentistry is really, come down to a couple factors. And one of the biggest things that we have to do as clinicians is communicate. And communication is a really vital part of our daily practice. And if we think about it, not only are we talking of this in terms of our communication with our patients and our staff, but if we think of communication in terms of what we can hear, we also associate sounds with everything that we do. So, if we're using an ultrasonic scaler, we associate the sound it makes when it contacts, a tooth in a certain way, and we associate that to whether or not we're using it properly. If we think about a burr, we associate certain sounds with the way it's contacting, a tooth or a crown, and we associate what we're doing based off of those sounds as well. So, being able to hear and being able to communicate is something that is primary to what we do. And if we lose that function and if we lose that ability to communicate with our patients and our staff, and if we're not able to hear those sounds that we need to hear more clearly, then it's going to have a direct effect on our quality of work and our practice.
What are the worst offenders that we have to look at for ear protection?
I think the most popular one we all think about is the high-speed handpiece. Those across the board are well in that range of causing hearing damage. Of course, we do have electric handpieces now, which are quieter, and definitely those help, but those are still high up in that range. I think what we don't realize is how everything else in our environment also causes a lot of damage. The high-speed suction is one that creates that constant kind of, suction sound, and that can be very loud. We still have the ultrasonic instrumentation, the ultrasonic scalers. Not only are they high decibel, but again, they're extremely high frequency. And so those are also something that can cause significant damage, not just for the hygienist, but, clinicians using them as well. And the dental offices, we're surrounded by noise all day long. We've got the autoclave, we've got our lab trimmer when we're trimming models, the ultrasonic machines when we're trying to clean some of our instruments. If you think about the walls within our clinics as well, we're basically sitting in a room that's surrounding us with this noise and helping make sure that noise kind of stays in there. So there's really kind of no escape for us.
Have you done, or do you know of any studies that have been done on rating the noise levels of high-speed air turbine handpieces, for example?
Yeah, absolutely. There's been quite a good amount of literature on that, and they've looked at different brands, and they've looked at the overall numbers as well. They're really finding that they're all well above the acceptable, range of what causes hearing damage. They're significantly higher. And if you go by some of the hearing standards and how long we're in theory supposed to be allowed to be exposed to those sounds before we create hearing damage, a lot of these handpieces that we work with are not allowing us more than a half hour of cumulative exposure a day before we create this hearing damage. And the important thing with hearing damage and noise-induced hearing loss specifically is that it's a phenomenon that's cumulative, that's additive, and that basically progresses over time. And so, if we were only working in the dental field for half hour a day, once a month, then maybe we'd be fine. But of course, our problem is our careers are around 35 years and growing, and we're there 8-hour days, 5 days a week. So the exposures that we have, they are cumulative, and that's what's helping create this damage. It's an issue of time.
So do you feel we actually need some sort of personal protection equipment? Do you yourself use anything or advocate it?
Absolutely. I have a product that we had designed that I use on a daily basis, and I absolutely think for anybody in the dental environment, any dental professional, we often focus on the dentist, themselves. But if we think about it, our assistant that's sitting next to us is exposed to the exact same sounds that we are. And what the literature has shown very clearly is that other people in the dental environment, dental hygienists, lab technicians, they're all exposed in this environment, and it really goes across the board. Definitely advocate using some type of personal protective equipment to prevent this from causing more damage to a career.
So if I think about hearing protection, I've got this picture in my head of wearing earmuffs like you would when you're mowing a lawn.
Yeah, so we've come quite a long way in terms of the technology. A lot of what we would customarily think of were these big, bulky type of muffs we'd see, at the airport. And clearly, as clinicians, we already have masks on. We're often wearing loops, and we have so many different things that we're wearing. The last thing we could possibly imagine is adding one more bulky unit into our ears that's going to be in the way. Technology, fortunately, has evolved, and we've gotten to a point now where there are different type of options available to us that not only are extremely small and are lightweight, but in terms of lowering the sounds, those high frequency, high decibel sounds that actually are contributing directly to our hearing loss, but they also will not hamper our ability to communicate with our patients and our staff, and it will allow us to still hear things the exact same as we would if we weren't wearing anything. And that's kind of how far technology has brought us.
Are you aware of any of these technological advances that may have been introduced into undergraduate curriculum at the moment, so that the young dentists are becoming aware of one of the long-term hazards, if you like, of clinical practice?
That's a personal goal of mine, not only is to try and educate the field, but to try and get this in the hands of students, since the exposure to these sounds basically starts with them day one of dental school. What we've seen across the board is that there is a very significant interest from dental students. They are a lot more technologically aware nowadays than they obviously were in the past, but I think that's hopefully the direction that we're headed to.
Well, we're a very conservative profession, and any innovation and change takes a great amount of time. But I'd like to say that I think we hear you, and I'd like to thank you, Dr. Sam Shamardi, for speaking to Dental Files today.
Thank you.